So we have with us Dr. Avnindra Gupta, who is a senior consultant at Center for Sight, plus he has his own practice in Faridabad. He is a high-volume surgeon, does a lot of posterior segment surgeries. So he will just give you tips in how to, if you have a PCR and if there is a vitreous there, what are the tips in anterior vitrectomy? Yes, Avnindra. Mike.
Hi. For giving me this opportunity of speaking on anterior vitrectomy. It will be a more practical oriented talk and most of it will consist of videos. Posterior capsule preservation is the most important step in management of cataract surgery for completion of surgery and for implantation of intraocular lens. PCR is usually associated with vitreous loss. Vitreous management is key to cortex removal and IOL placement. Good vitreous management lead to decreased postoperative inflammation. Many times you will have vitreous prolapse into the anterior segment. This will cause decentration of IOL. The pupil will be distorted and patient will keep on complaining of glare. There is a decreased posterior segment complication if you do a good vitrectomy like CME and retinal detachment. Maintenance of anterior chamber throughout the management of the posterior capsular rent and anterior vitrectomy is of prime importance to prevent any kind of complication. What should you do? Cortex and vitreous is restricted to anterior chamber. First, use viscoelastic to stabilize the AC and push the vitreous behind. Your flow rate should be decreased and to decrease the turbulence, because more the turbulence, more the vitreous will come. Combine vitrectomy and aspiration of cortex. Place the IOL over the rhexis, and usually it should be a 3-piece IOL. Before going for anterior vitrectomy, most of us should know our phaco machine and how to attach a vitrector. Because for an anterior segment surgeon, PCR is an emergency situation, because he knows कि लेंस अब पेशेंट को जवाब क्या देना है कल, अब लेंस डाल पाएंगे कि नहीं डाल पाएंगे, कॉर्टेक्स रिमूव कर पाएंगे कि नहीं कर पाएंगे. So he should, and the attendant or your OT technician should be well versed with the machine. So if you are going to another center, a dry run should always be done. There should be an availability of good cutter. And vitrectomy should be done in a closed wound. It should be a closed chamber. It shouldn't be an open chamber. So if you are doing an ECC also, put sutures. If it is a phacoemulsification, do from 2 paracentesis. It should have high cut rate and low suction. Use paracentesis for bimanual vitrectomy. Mouth of the cutter should be towards you, and it should not be facing towards the iris or the posterior capsule, because the cutter is so fast, moment it sucks the iris, it's just a fraction of a second, it will cut your iris. So it should be always towards you and away from the iris. Be away from the iris and capsule, as you can damage both. Lot of videos you must have seen कि you put tricot, but if you put tricot without an IOL, the tricot will precipitate into the mid-vitreous cavity and you will be unable to remove this tricot. So tricot should be put after the IOL is placed. This is one thing what I wanted to say. In normal machine, what happens, the paddle 1 you see infusion, paddle 2 cutting comes, and paddle 3 aspiration. So in Alcon machine, or if your machine can go on to this setting, that is paddle 1 is infusion, paddle 2 aspiration, and paddle 3 is cutting. So what the advantage of this position is, at paddle 2 infusion is on and aspiration is on. So your cutter works as an IA system. It works as a bimanual IA system. The moment the vitreous comes, shift on to paddle 3, do some vitrectomy, and again shift on to paddle 2, it works as an IA and you can remove the cortex. So frequent change of instrumentation is not there if you put this second setting into your vitrectomy machine. If you have any nucleus or the nucleus fragment, it will not come with the cutter. You have to remove this either with a fragmentome or with a phacoprobe, or you have to do a visco expression of this nucleus fragment, because these are hard and you cannot cut this. Once the visco expression is done, the lens is placed and you then do a vitrectomy. You can see the port is towards you, the visco is removed. You go on the side with two, it's usually bimanual from the side port. You go on the side of the iris. If there is any vitreous, just remove it. Put an air bubble. If you get a single air bubble, it's a classic teaching that there is no vitreous. Then you can see here, I'm doing a bimanual aspiration. There is a big rent here. You can see there is a rent. And every time you go for a bimanual, this vitreous comes into your aspiration port and it blocks it, so you are not able to aspirate the cortex. So what I do is I go ahead with a cutter. You can see this is a cutter here. You have to go at the plane of the posterior capsular rent. Ideal is not to go from the main wound, go from both the side ports. Go from both the side ports, cut the go from both the side port, cut the vitreous, and then remove the last bit of cortex. And believe me, if you have done a good vitrectomy, remove cortex, then it is as normal as without a rent. Only two things you have to manage. Post-operatively, these patients will do very well. 3-piece lens is placed over the rexus, and day one, this patient was doing pretty fine. This is another patient. You can see here, it's an opaque IOL. What we do here is we create a space between the rexus. We try to pull the lens, but the lens is stuck. There is a capsular lens adhesion. Whole of the bag is coming out. So at this stage, we decide to cut this lens and then remove this lens. Now there is a posterior capsular support available. The lens is explanted, and once we explant the lens, you can see already the yak capsulotomy has been done in this patient. There is a big posterior capsular rent, and we place the IOL over the fibrosed capsule and put tricot. Other thing is, if you are not comfortable with a bimanual system, you can put an AC maintainer kind of a thing, what you have put here. From one of the paracenteses, you can put an AC maintainer. There is a continuous flow of fluid, and the chamber is maintained. And once you do this, you can do a nice vitrectomy, close the wound, and the vitreous is taken care. In this patient, we have done a refractive exchange. So since that capsule is deficient, and I expect I won't be able to place the lens over the deficient capsule, so we are also planning for glued scleral fixated IOL. So I have placed an trocar cannula system here that if I have to do a SF IOL, I will be able to do with this trocar cannula system. The lens is removed. The 3-piece lens is placed over the rexus margins which are available. It is dialed. You can see the lens is stable, so we didn't require a glued SF IOL. You can see a lot of pigment is there, a lot of vitreous has come because the capsule is deficient. So what we do, we put on the infusion into this cannula system and start doing a vitrectomy here. And I go on the besides the margins of the lens, cut all the vitreous, remove all the pigments. At this stage, I realize I have not done a good vitrectomy, and there are a lot of pigments here in the vitreous posterior to the lens. So I change the infusion, make this as an AC maintainer, I use this port to do an pars plana kind of an anterior vitrectomy, which is pretty easy to do and very conclusive because you are pulling the vitreous from behind and it doesn't comes into the anterior chamber. You can see all the vitreous opacities has been removed. The media is absolutely clear, and this patient had a very good visual recovery without any floaters. This is one of the patient who had needle stick injury. We did an ultrasound for this patient. There was a pre-existing posterior capsular rent. The age of the patient was somewhere around 20 years. So I said to my anterior segment surgeon, he said it's just cortex aspiration. But I said you will land up into a problem, so I have already placed a trocar cannula system. He's doing an irrigation aspiration of the cortex. After doing 10 minutes, he's stuck because it's mixed with, cortex is mixed with vitreous. You can see he's trying to manipulate, but it's not helping him. The cortex doesn't come. So what I do, I go from behind, I just make another port and do a vitrectomy within cortex aspiration. I am not doing a 3-port vitrectomy. The concept, what I told you earlier, is that you cut the vitreous, put the cutter off. Now this works as an IA system. So here you can see I am going between the capsule and I am just using I am not using the cutter here because the moment I cut the cutter, I lose the capsule. I am using this as an IA. The fluid is coming from here, and this works as an IA, but it's from the pars plana. So you can see how nicely I am able to remove whole of the cortex, and the cortex is removed. The moment the vitreous comes, you shift on to the vitrectomy mode, cut the vitreous, and again put off the cutter. Like this, whole of the cortex is removed, and I have also preserved the capsule which is available. And this capsule helps me to place an lens over this over the rexus, and now I am putting a 3-piece lens, and this patient improved to 6/6 vision. To conclude, PCR and vitreous loss is inevitable part of phacoemulsification surgery or cataract surgery. Managing complication the right way makes you a good surgeon. 90% of your cases will be fine, but whosoever manages this complication is the best surgeon. Do not rush into putting IOL. Do a good anterior vitrectomy and cortex removal, which prevents a lot of post-operative problem. And if you do this, your patient will be as normal. You can even put any kind of IOL, the lens will be centered. And lastly, knowing your machine prevents intraoperative palpitation. So don't say once the rent occurs, then you ask your technician, bring the cutter, bring this, bring that. It's a chaos. Everything should be quiet and should work like a music once you have a complication. Thank you very much for your kind attention.
Thank you, Avnindra, for this multiple tips. Anybody has any question to ask, feel free, because the name of the session itself is tips. Otherwise, I'll make a couple of comments. Yeah, anybody? So, very good suggestion was that tricot should be placed after you have done the IUL, after you have put, because otherwise tricot may percolate and you may have to, although it's not a disaster if it goes behind, because it will in any case help in inflammation. But that's better. Second point was about, Avnindra, you showed both the kinds of vitrectomy, anterior as well as posterior, because a lot of us advocate vitrectomy from the pars plana, because if you cut vitreous from behind, vis-a-vis if you come from anterior segment, then the vitreous behind will have, propensity to come anteriorly. So what do you advocate?
Ideal situation is you should be doing vitrectomy from the pars plana. What happens if you do from the anterior segment, the fluid goes behind, it hydrates the vitreous, and more and more vitreous comes. More vitreous comes, it tends to extend the posterior capsular rent, and you have to work near the lens, so capsule and the iris, and many times you can cause an extension of the posterior capsular rent. If you have a posterior capsular rent, if you can maintain the size of the rent, that is the success of the surgeon at the moment. If you do from behind, you are pulling the vitreous into the vitreous cavity. You are going into the enemy's territory, and here the enemy is vitreous, and you are going into enemy's territory, that is vitreous cavity, and attacking it there. So once you are attacking it there, the results are much better as compared to anterior. But mind you, all anterior segment surgeon has a fear of entering through pars plana. That fear has to go out from the mind, and you should have a trocar cannula system and a good 23 gauge.
Believe me, this point has been emphasized, but fear still
I
exists.
think more than fear, actually, the anterior segment surgeon's list is so heavy, and though it may be notional for 3, 4, 5 minutes, but somehow or the other it gets there into their mind that you now remove the phaco probe, put on a vitrectomy cutter, go from here. So I think because they probably, because most of them will be having 10, 20 cases lying behind. So some of the centers actually advise if there's a PCR, don't move any further and post it some other day, so that you have to relax time and do whatever you want to do.
The other point I wanted to make was about once the vitreous is mixed with the cortical matter, because a lot of people still keep aspirating. That is not good. But that is the time to put suture and have an automated instrument like cutter, because that will cut the vitreous as well as cortex. Because if you keep aspirating vitreous with cortex, that will never come out. And the third point I think I wanted to emphasize was a working cutter, because once you are doing a vitrectomy, often you don't see the vitreous, because vitreous is a clear kind of gel. You may not see the vitreous. So you are doing tick, and vitreous, you may not be cutting, because vitreous is not visible. So sometimes to make vitreous visible, you inject 1 or 2 drops of tricot to make vitreous visible. So otherwise vitreous may not be visible. And if you, because the PCR rates are not very high unless you are in the initial stage of your career. So a cutter should be good, because sometimes if you take an old cutter left over by somebody else, it is not working. This cutter will suck more and cut less. So that is not done.
Is there any way to find out whether cutter is working or not?
No, you
Actually,
No, because you are right. I mean, if the Alcon is charging some 25,000 for a kit and you are charging, say, 30, 40,000 for a cataract, and the PCR happens, and you open a 25,000 kit, will be, I think, very, very difficult for us to really digest that you'll open a 25,000.
Sometimes these old cutters may be jammed, because you open it so
No, I got
rarely.
a point, but besides the movement, which you can see on a ball, whether the cutter is moving to and fro
Surgeon
or
is
not.
thinking that he is
but
actually
you can see
cutting.
the vitreous fibrils, and many times if you can't see, you can use an indo illuminator to see it.
No,
And
cutter
what-
movement is there, that you can check before entering inside the eye, whether the tip is moving or not, that you can check. But whether it's a cutting or not, is there some tissue to cut it before you cut the vitreous or something? Something like we do the vitrectomy or something. I mean, there should be some maybe artificial material. You can check it whether it's a cutting is all right or not. Because for anterior segment surgeon to open a new set every time he has got a PCR will be probably not very cost
A
effective.
single cutter you can use for at least 8 to 10 times. But you should not be using that cutter indefinitely. That is the thing.
No, not indefinitely. Actually, like he was saying,
the
because
reason-
many a times the anterior surgeons, the OT technician also not very well trained to clean the cutter properly. So when you use first time, it may be actually, get second time may not be in a very good shape.
So
very
that's
good
what
shape.
if I told in my talk before, you should be well versed with your machine, the cutter, and the technician should be well versed in putting that. It should work as a music. It should not be an emergency condition in the.
So your eye should be looking at a vitreous fibril, because if it's a vitreous fibril which is organized, you will see the movement of cutting, or the cortex. Suppose there is some cortical matter, so you'll see the cortical matter getting cut and aspirated. Short of that, if it's absolutely clear, there's no only vitreous. Sometimes it's difficult to see, so I'll put 1 or 2 drops of tricot. That will make it 100% seen whether vitreous is there or not. That will make it 100% visible. Because doing a blind vitrectomy vis-a-vis a visualized vitrectomy is better. Okay, now, Punita.
Vitrectomy, like anterior vitrectomy, because the vitreous is mixed with the cortex matter. So you can easily cut the iris and go behind and damage the cerebral body. How to prevent that?
And that's what I showed in my video. You can cut away from the iris. The cutter should be towards you and not towards the iris. And the system what you first as paddle 1 aspiration in fluid, paddle 2 is aspiration and 3 is cutting. So the moment the vitreous is not there, you can work with that cutter as an IA system. And the moment the vitreous comes, you go to the cutter mode, remove the vitreous, and again keep on working on IA mode. Last 2 cases were like that only, and I was able to preserve the capsule, remove all the cortex, and place the IOL over the remnant capsule.
Okay, we'll move on. We have with us Dr. Harbans Lal, and his practical tips. If you read his book, which was written more than a decade back on cataract surgery, you actually feel that you are